Hey everyone, and welcome to this explainer. Look, if you're an ophthalmology resident, you already know that interpreting a fundus fluorescein angiography, an FFA, can sometimes feel, well, a bit like trying to read a map in the absolute pitch dark. But today, we're going to completely demystify the whole process. We are focusing on mastering retinal pathology identification using a really effective baseline to deviation framework. By the end of this, you won't just be blindly memorizing textbook images. Nope. You'll be logically deducing exactly what is happening anatomically inside the eye. Okay, let's dive into this. Our roadmap for today is super straightforward. First, normal angiography phases. Second, decoding hypofluorescence patterns. Third, hyperfluorescence, leaks and pools. And finally, number 4, hyperfluorescence, windows and scars. All right, section 1, normal angiography phases. This is all about establishing the baseline chronology. You know, rote memorization just completely fails you in a busy clinic if you don't have a solid baseline. So we're going to meticulously track the dye's chronological journey right from the arm, through the vasculature, and into the eye. So you inject the IV fluorescein. At about 10 seconds, the dye hits the choriocapillaris, giving us this patchy, mottled background we call the choroidal flush. By 12 seconds, we hit the arterial phase. That's your arm to retina circulation time. At 16 seconds, we're right into the venous phase, where the dye totally fills the entire lumen of the venules. Then, around 25 seconds, we hit the peak phase. This is when those tiny, fine parafoveal capillaries are imaged the absolute best. And finally, somewhere around the 3 to 5 minute mark, we're in the late phase, which just shows the gradual elimination of the dye. Oh, and keep in mind through all of this, the foveal avascular zone, the FAZ, normally stays totally dark. Why? Well, it lacks blood vessels, and the retinal pigment epithelium, the RPE, physically blocks the underlying choroidal fluorescence. Moving right along to section 2, decoding hypofluorescence patterns. Basically, what's going on when the angiogram is just too dark. So, now that we have our chronological baseline, let's pivot sharply to our very first deviation, hypofluorescence. This simply means the angiogram is too dark. Whenever you see an abnormally dark patch, it means one of two things. Either the dye is there, but it's physically blocked from your view, or the dye just literally never arrived in the first place because of a filling defect. Now, what's really interesting about this is how we can use blocked fluorescence to ground a flat 2D image into 3D anatomy. Take a pre-retinal hemorrhage. It sits directly in front of the retina, kind of often taking on a boat shape. Because it's in the very front, it completely blocks your view of both the retinal vessels and the underlying choroid. It's basically a total blackout. But look at a subretinal hemorrhage. Because it's located underneath the retina, it only blocks the choroidal fluorescence. If you look really closely at an angiogram of this, you'll actually see glowing retinal blood vessels passing seamlessly right over that dark, blocked area. Seeing that vessel literally cross over the dark patch instantly gives you the 3D depth you need to confidently diagnose it as subretinal. Okay, so what if the cause of a too dark angiogram isn't a physical block, like blood? What if it's a filling defect? Well, that brings us to capillary non-perfusion, or CNP. These are areas where the capillary network has essentially just died off, meaning the dyes simply cannot perfuse the tissue. When those capillaries drop out, you get these massive, black, hypofluorescent areas that are huge red flags for severe retinal ischemia. So where are we actually going to see this capillary non-perfusion in practice? Mostly in ischemic conditions. Let's think about a central retinal vein occlusion, a CRVO. You can have a non-ischemic type, right, where you mostly just see blocked fluorescence from hemorrhages. But if you have an ischemic CRVO, the presentation is drastically different. Clinically, you'll see cotton wool spots, and on the angiogram, you're going to see a massive black hypofluorescent background because the capillaries have totally dropped out. I mean, it practically screams severe ischemia. You're also going to see this capillary dropout in branched retinal vein occlusion, severe diabetic retinopathy, and even as an abnormal expansion of that foveal avascular zone we talked about earlier. All right, section 3, hyperfluorescence, leaks and pools. This is how we categorize those too bright lesions. We've covered the dark patches, so let's transition over to hyperfluorescence. This is when the angiogram is too bright, meaning there's an increased intensity of fluorescence. Now, to truly master this, there are 4 distinct patterns we absolutely must memorize: leakage, pooling, transmitted fluorescence, and staining. So the crucial point here is this specific matrix. If you commit this to memory, you'll be able to instantly differentiate all 4 types on your next shift based entirely on how the bright spot behaves over time. You gotta ask yourself, does it change in size? Does it change in intensity? What do the margins actually look like? Keep this matrix in the back of your mind as we break each one of these down. Let's start with leakage. And the ultimate textbook pathological example of leakage is the choroidal neovascular membrane, or CNVM. Anatomically speaking, these are abnormal, highly incompetent vessels that originate down in the choroid, aggressively break right through that RPE layer, and invade the subretinal space between the RPE and the neurosensory retina. Because they absolutely do not belong there, they are incredibly leaky. I mean, leakage literally means the dye is physically escaping from incompetent blood vessels. In a classic CNVM, or honestly, even with neovascularization elsewhere on the retina, you'll typically see an initial lacy pattern of hyperfluorescence. But as the angiogram progresses, you really gotta watch closely. That bright spot progressively enlarges in size and it massively increases in intensity. It starts glowing almost like a light bulb. Plus, because the dye is just freely spilling out into the surrounding tissue, those margins are going to look remarkably fuzzy and ill-defined. Now let's move to pooling and see how this builds on our understanding of fluid dynamics inside the eye. Pooling also increases in intensity, exactly like leakage, but with one massive, crucial difference. It fills a distinct anatomical pocket or cavity, and then it strictly stops growing in size. The dye literally gets trapped. Some classic, really evocative visual mnemonics for this include the smokestack appearance in central serous chorioretinopathy, CSR, where the dye rises up like a puff of smoke filling a subretinal space. Or you might see the ink blot pattern in CSR, which spreads exactly like a drop of ink on a piece of filter paper until that pocket is totally full. You'll also see pooling in the multiple serous exudative detachments you get in VKH, or Harada disease, and in pigment epithelial detachments, where the fluid pools entirely in that sub-RPE space. Which brings us to our final section, Section 4, Hyperfluorescence, Windows and Scars. Let's look at transmitted fluorescence and staining. So we just talked about leaks and pools, right? Those involve active fluid movement. Now we're looking at transmitted fluorescence and staining. For both of these specific patterns, the physical size of the bright spot on the angiogram remains stubbornly fixed from start to finish. It doesn't grow. First up is transmitted fluorescence, which is super commonly known as a window defect. Remember our baseline? The RPE normally blocks the bright choroid from our view. But if there is an atrophy or a physical defect in that RPE, it creates a literal physical window. And this brilliantly illustrates our baseline chronology from earlier. Because this is just a window looking down into the choroid, this hyperfluorescent spot is going to light up during the choroidal flush phase, literally before the retinal arteries even start filling. It fills early, its intensity perfectly matches the choroid, and its size never, ever changes. A really prime example of this is the geographical atrophy we see in age-related macular degeneration. And that leaves us with our final hyperfluorescent pattern, staining. Staining happens when tissue actually absorbs and physically holds onto the dye. Now, unlike the super early appearance of a window defect, staining occurs quite late in the angiogram. The tissue gradually gets brighter, but it's really only a mildly intense hyperfluorescence. It definitely doesn't glow aggressively like a leak does. And crucially, the dye never extends beyond the strict physical limits of the tissue that's holding it. The size is absolutely 100% fixed. You're going to see the specific pattern in scars, areas of fibrosis, and in both hard and soft drusen. So let me just leave you with this final thought. On your very next clinical shift, when a bright spot on an FFA progressively enlarges, and it's got those fuzzy margins, will you know exactly what is happening anatomically? Well, armed with this baseline to deviation framework, you should instantly recognize that as leakage from incompetent vessels, maybe a CNVM, rather than, say, a fixed-size window defect or a confined pool of fluid. Mastering these visual patterns isn't just about acing your exams. It is the ultimate key to quickly diagnosing pathology, guiding treatment, and ultimately preserving your patient's vision. Thank you so much for joining me on this explainer, and I will see you next time as we continue to break down the complexities of clinical diagnostics.